So welcome everyone who's here with us on Zoom, as well as everyone who's here with us on Facebook. We're so excited to have you here with us today to talk about spinal cord stimulation with Dr. Shalini Shah. Next slide, please. So my name is Emily Lemiska, and I am Director of Communications and Educational Programming, and I will be your host today for this event. I'm going to go through some housekeeping items and introductions at first, then we'll hear from Dr. Shalini Shah, and then finally, we're going to open it up to some questions and answers, and we've already gotten a lot of great questions from our audience. I think maybe the most questions we've ever gotten before a webinar. So really excited, and we're going to make sure we dedicate a lot of time to answering those. Next slide, please. So we are, for people on Zoom, you'll note that your camera is off and you're on mute. The way that you can ask questions is by typing them into the Q&A button. We also do have the chat open, so you're welcome to use that, although, please be respectful of one another. But if you have a question for Dr. Shah, make sure you type that into the Q&A panel because that makes sure that we'll see it. Sometimes questions get lost in the chat. If you're joining us on Facebook, you can just type your question into the comments and we will be pulling in those questions as well. And we'll try to get to as many questions as we possibly can. This webinar will be about an hour, but if you have to jump off early, don't worry. We know it's a busy time for everybody, and the recording of this will be available in just 2 to 3 days. We'll post it on our website, uspainfoundation.org/webinars, and we'll also have it as a link in our newsletter, which is coming out next week. So, next slide, please. And just a little disclaimer before we begin, US Pain does not endorse or recommend the use of any particular treatment or product. This webinar is educational only. It is not meant to constitute medical advice. Always seek the advice of your healthcare provider if any questions you may have. We are all so different, so it's really important you talk to your provider about your specific condition and your unique situation. Next slide, please. And I want to take a moment today to thank our sponsor for today's event, Boston Scientific. This is made possible through their generous support, so we really appreciate you. Next slide, please. So with that, I'd like to introduce Dr. Shah, and I'm going to tell you a little bit about her background as an interventional pain specialist. So Dr. Shah serves as Associate Professor and Vice Chair for the Department of Anesthesiology and Perioperative Care and is Enterprise Director of Pain Services for the University of California, Irvine Health. Dr. Shah completed her residency in anesthesiology from Cornell University and a combined fellowship in adult and pediatric pain medicine at Harvard Medical School. She is the founder of the Pediatric Pain Program at University of California, Irvine, and has previously served as Associate Program Director for the Pain Medicine Fellowship. Dr. Shah is the recipient of the American Society of Regional Anesthesia and Pain Medicine Chronic Pain Grant Award in 2017 for her work in Botox use in pediatric migraine pain. She currently leads several industry and NIH peer-reviewed funded clinical trials in pediatric and adult pain medicine. Dr. Shah presently serves as the founding chair, Committee of Pain Medicine at the California Society of Anesthesiologists, and is strongly committed to pain advocacy and regulatory reform both in the state of California and nationally. And we love to hear that. She is the president-elect for the California Society of Interventional Pain Physicians. So as you can tell, we are very fortunate to have here with us today. I can't imagine a better person to speak to us about spinal cord stimulation and SCS. So with that, welcome, Dr. Shah. Thank you, and we'll let you take over from here.
Thank you. It is a real honor to be here with everyone. I'm going to start sharing my screen so we can get our presentation up. Okay. There we go. Emily, do you see that okay?
Yep, looks perfect. Actually, it's not quite full screen yet.
There we go. Is it better?
Yep, perfect.
Alrighty. Well, good morning to everyone, or if you're on the West Coast, good afternoon if you're on the East Coast or Central. It's really an honor for me to be in front of you today to talk to you very casually and really answer your questions about spinal cord stimulation, and more than that, really about pain. You know, a lot of us have pain, and sometimes we just don't have the ability to talk to a pain physician directly, someone with the expertise, or may have difficulty with referrals from your PCP to pain management. So this is a great opportunity. We'll keep it comfortable, cozy. I hope I get all your questions in because I'm really, really looking forward to this. So I want to put out a disclaimer. I think this is really important. I don't have any financial relationships with any of the manufacturers of spinal cord stimulation. So this is a really unbranded, talk that can be manipulated in any way. So I just wanted to put that out there. So today's objectives. We're going to talk about the history of spinal cord stimulation. How did the technology even come about? How does it work? Who is it right for? Is it right for everybody? Is it right for me? Is it not right for me? This is what I'm going through. Will I benefit? And then what to expect. And I think this is really important to talk about expectations from this device. What are the side effects and complications? And I really want to have an honest discussion with you to explain to you what are the possible side effects from anything that we do, specifically with spinal cord stimulation, and then how to find an interventional pain specialist. Okay. So first, let's talk about the electrical stimulation history. I'm not sure how many of you may know, but we have been using electrical stimulation to treat pain since the ancient Egyptians and ancient Greeks. This is an example of a torpedo fish that's from the Nile catfish, which can, when the torpedo fish aligns itself with your skin, can send electrical stimulation to your body. The first indication was of this, and this is from the ancient Greeks, was for the indication of gout. They would have patients who suffer from gout in their feet sit in the water in the river and have the fish come and provide the electricity so the patients could get some relief. So this is 5,000 years ago, folks. Then in the 1700s, we learned how to control the energy. So we created the Leyden jar, which allows us to generate, store, and discharge electricity when we need it. So you can see it's getting more and more sophisticated. And this is something that you may have seen already or be currently using, and that's the TENS device. This is the modern day application of electricity, where we put on the electrode pads wherever we feel the pain, we attach it to the beeper, the battery pack, and we turn on the electricity. And you could be sitting at the computer doing some work, household chores, and get some relief. It's a great device, but one of the limitations is that once you take off the pads, you turn off the device, the pain relief goes away. So it is only active if you're wearing the battery pack and you're wearing the leads across your body. And so I wanted to provide to you some history and some scientific data of how does this work. The theory behind it is by a very, very articulate paper written in 1965 by Drs. Wall and Drs. Melzack, which elucidated the mechanism by which when we give electricity to a certain area, we can actually prevent the pain signals from entering the spinal cord. So I'm going to say that one more time. By stimulating some fibers, we can block the pain signals to get to the spinal cord and then get to the brain for processing. And that's how it works. It's a very elegant paper that described the system, and it's the basis of our TENS unit. It's the basis of our spinal cord stimulation. Then in 1967, a neurosurgeon named Dr. Norman Shealy, who's still alive today, used that concept that was described by Drs. Wall and Melzack to create electrodes that he would implant surgically along the spinal cord and hook it up to a battery for pain relief. And then we have come to where we are right now, which is the sophisticated mechanisms of spinal cord stimulation. So The technology has been developed for over 40 years. This is nothing new. It's not a breakthrough medical device that has just come out. We know how it works. We've tried it for over 40 years, tried and true, and we know the side effects and what to expect from it. It is FDA approved for pain. And the benefit of it, in my personal opinion, is that it's a non-drug therapy. You know, when you turn on the TV nowadays, when you watch the news, you can find a plethora, dozens and dozens of commercials for drugs, for medications. And typically when you go to the doctor's office, you have something, you just get a prescription. But the reality is that sometimes these medications do interact, and oftentimes they have a lot of psychological, psychiatric comorbidities or psychiatric side effects to some of these medications that may be just too sedating. And so this is a technology that doesn't rely on medications. It doesn't alter your mental status. It doesn't have any untoward side effects. And so it's a really, really good option for treating your pain. It is covered by Medicare. So if you're a Medicare beneficiary, it is a covered benefit, as well as workman's comp and most, if not all, insurance plans. And I'm going to share with you some new improvements. Yes, the technology has been around for 40 years, but over the last probably decade, we have just exponentially increased our knowledge of how we can apply dosing for electricity. So we're going to talk a little bit about that, and then some side effects. Okay, so the basic premise is that it uses electrodes that we implant in the spine, and you get a little battery that's about the size of a silver dollar that we implant somewhere in the abdomen or in the buttocks. So here is a video that can simulate what you can expect. So here we have this gentleman here with foot pain, and the pain signal goes up from the nerves to the spinal cord and then to the brain for processing. And anyone who has pain knows that those signals are much more frequent than a normal signal would be. So the problem with pain is that you get an abnormal barrage of pain signals entering the spinal cord and then the brain. So the way the stimulator works is that we implant these two leads plus the battery. And these batteries are so sophisticated now, they're so thin, to block the pain signals using that gate theory that we talked about. Okay, so you can see the pain signals may still be coming, but now they're blocked with the electrodes. This is a gentleman with arm pain. He has the spinal cord stimulator over him, and it gives a paresthesia sensation. Paresthesia is another word for the TENS device that you feel, that vibration. So the vibration pretty much maps over the area with his pain. So he may feel some mild vibratory signals, but he's not feeling the pain. In fact, the technology is so great now that we can actually have a paresthesia-free opportunity, so that pains, you don't even feel the vibrations. The program is so sophisticated now. And we can have pain relief in multiple areas. So sometimes, I get a patient comes in and says, "Doc, I've got this low back pain, but it also goes down my leg and it also goes down to my foot. Can this device help me for that?" And the answer is yes. So we can treat multiple pains at the same time. So this is an example of what you may or may not have seen, but I wanted to put this in so you get an idea of what it looks like from an X-ray perspective. So this is a lead that's implanted on the left-hand side of the screen in the cervical neck region, and you can see it if we turn the X-ray and we get other measurements. If we look at the X-ray from the side of the neck, you can see again, that's your spinal cord lead sitting on the posterior, which means behind aspect of the neck. Now, you may be asking, how do you know where to put it? This is a very, very highly expertise field of understanding stimulation and understanding how the spinal cord is made. So Mother Nature has made it so the spinal cord, you can see, has different layers to it. The layer that's in the most, what we call the medial or the middle, is the thigh region, the buttock and thigh region. And as we go out to the side, you can see now we're able to get the foot, the anterior leg, the thigh, the low back pain, and the abdomen. Okay, so it's really important that you find an interventional pain physician who understands these layers and can put And remember that real estate in the back portion of the spinal cord is so tiny. So every millimeter matters. So it's really important where we put it so that we can capture the area of the pain. Again, this is taking electricity and changing it to neurochemistry. So this is an example of the lead that you see, alternating black and white electrodes, which means alternating positive and negative electrodes. And as they interface with each other, they're able to send cell signaling to the nerve. And what that means for you is that when the cell signaling is sent to the nerve signal, or to the neuron, excuse me, the nerve signal is not able to be propagated, which means it doesn't allow for that transmission of pain to occur. It doesn't allow the cell to say, hey, let's fire. It blocks that opportunity for the nerve. And so that's the mechanism by which it works. Very complex, but I wanted to bring it home to you so you get an idea of what the technology does. Because sometimes, you're given an opportunity to learn about a medical device, but you don't have that time to sit in the doctor's office and say, can you explain this to me more? Can you explain me exactly what it does? Will it work for me here? Why or why not? So I hope this is resonating with you and you're understanding how this works. So again, we have different options because the programming now is so sophisticated and so complex. We can program which contact is going to talk to which contact of which lead. So we can treat the back, we can treat the knee, we can treat the leg, we can treat the foot, we can even get some of the torso or the arm. It's really, really beautiful now how these programs can talk to each other. Some patients say, you know what? I want to feel the vibration because it's soothing to me, just so that I know the vibration is there and I don't feel pain. But I've got some patients who come into the office and say, doc, I don't want to feel anything. I just want that device in. I just don't want to feel pain. I don't want the vibration. And we can give you that too. So it's really up to your comfort level. We can build in 5, 7, 10 programs for you to play with. You can turn it up. You can turn it down. On those days where you're saying, I'm not doing much at home, I can relax. I probably don't need it. You can even turn it off. Those batteries are rechargeable and they'll last for 6 to 8 years, depending on your manufacturer and depending on how much you charge. So again, it's a durable medical equipment that's going to be implanted. And if you like both, you say one day I want to feel the paresthesias, the vibrations, and another day I don't. You don't need to. So it's up to you. It's completely personalized medicine. So who can benefit? I'm going to give you some examples of patients that are the best candidates. This list is not exhaustive, so there are many, many more patients that could benefit from this, but I'll just share with you some common diagnoses that we see. Typically, we see patients who have low back pain or nerve pain, what we call neuropathy, that goes down the legs. Talking about neuropathy, we also have patients who have diabetic neuropathy. Diabetes is one of the 3 most prevalent diseases in this country, and diabetic neuropathy will occur in patients. And this is a fantastic option for those patients who are really suffering from that nerve pain that diabetes brings on, and that medication is just not helping. We also have a lot of patients come into our office who had herniated disc and then went on to have spine surgery, and they went on to have a fusion, and then they had to have that fusion extended. And you can imagine what I'm trying to explain here is that sequelae that occurs from the first surgery onto the second, onto the third, and still no significant relief. We call that failed back surgery syndrome, and this is a fantastic option if you're suffering from that. Something called CRPS, complex regional pain syndrome. It's an incredibly debilitating pain syndrome for patients. It's also known as RSD, and this is another fantastic option, especially when you've tried the nerve blocks, medications, and nothing else is really helping. If you've been suffering from chronic pain for longer than 6 months, you've taken all the medications and you've tried the injections, it's still not helping, this is a great option for you. So, some patients who come to me and they say, Dr. Shah, I really have this herniated disc, or I really do need a fusion, but I'm just not ready for surgery. I just don't want to go there yet. Are there any other options? This is a fantastic option. We do a trial first. That means we put the leads in and we send you home. And you trial it out for anywhere between 3 days to a week, and you come back. and you let me know, yes, this worked for me. Hey, I'm able to do much more than I was able to do before. You know, doc, I just didn't need as much medication, or I slept better. So these are fantastic options without having to go into a permanent surgical solution that you can trial at home to see if you like it before you make it permanent. For patient screening, we also want to make sure that, you know, this is the right type of pain. The current regimen that you've been on has not provided sufficient relief. And what does that mean? You know, you've done the physical therapy, you've done the interventions and the injections. Although they've helped in the past, now you're getting to a point where they're just not helping as much. You've done the pain psychology. We want to make sure that you're abstaining from alcohol, opiates, and tobacco during this time period, particularly tobacco, because it does interfere with wound and cellular healing. And then we will also get typically some labs or imaging studies to make sure that your platelets and your blood coagulation is appropriate and healthy, and that you don't have any structural abnormalities that we wouldn't foresee. So typically your doctor will also order some imaging, like an MRI prior to the procedure. We will also send you for pain psychological evaluation. And this doesn't mean that you're crazy. And I really want to preface that. And I say that to all my patients. The reason is that pain and anxiety and depression travel together in the spinal cord. There is a neurological, biological reason for why patients who have pain also develop anxiety, and after the anxiety phase, go into a depression. Okay, it is normal, it's expected, especially with patients who are taking signals such as pain constantly. You cannot function with pain and plus anxiety and plus depression. And so for that reason, we really want to make sure that you are a psychological fit to have a medical device. And so that's why we will send you for an evaluation to make sure that you're going to respond appropriately. There are some patients who have so much depression they cannot determine if there's a response or not, and they probably are not a good candidate for this type of procedure. So that's why we really want to prepare you so you know what to expect, help you with your anxiety and depression, and bringing that down prior to putting in or trialing a stimulator. So let's talk about the process. Okay, so as I said, we're going to send you home with a trial. You'll come into the clinic. Typically, your pain physician will put in the leads and map it out, and we ask you a lot of questions. We talk to you. Is this over the area of your pain? No, doc, can you move it more left? Can you steer it more right? A little bit higher, a little bit below the buttocks, maybe a little bit on the outer thigh. We tailor it to what is that you need and where most of your pain is. And then we send you home. There's no surgery, there's no incision, just a small puncture. We tape you up. And then we're gonna call you. Typically we call you every day just to check on you. And we're gonna see you back. And what we're looking for are three big things for me, at least. I'm looking for at least a 50% reduction in your pain. I'm looking to see, are you more functional? Meaning, were you able to now take a walk around the block? Will you now be able to do more chores? Were you able to go to work and function more appropriately because you had better pain relief? And the last thing I'm looking for is to decrease your medication use. I have patients who come in and say, you know, I've been on these opiate medications for decades, and now with the stimulator, I just didn't need as many. I was able to go from 4 pills a day down to 3 pills a day. And that's a big victory, you know, coming down on your medications. So those are the three things that I'm looking for principally. I also ask about sleep. Sleep is so vital to pain and pain functioning. So if you're able to get a good night's sleep for the first time because you had good pain relief, again, another great victory, right? These are the things that matter to you and that matter to us and that matter to success. So those are the things that we're looking at when we do the trial. Now, when the trial is completed, then we'll come back and we'll have a discussion of how to make this permanent. Okay, and so when we make this permanent, we can talk about surgery. It's a same-day surgery, so we bring you into the hospital after the surgery is completed. Once you meet the recovery room criteria, you can go home. We'll send you with the programming and talk to you about how it works. But in terms of complications, you know, the most frequent complications that we see with this device is sometimes the lead migrates. Sometimes we'll migrate one segment down or half a segment down. That's typically the most frequent complications. Infrequently, we'll see the very, very rare complications, allergic reaction, skin erosion. Sometimes a blood clot can form because of bleeding. Some patients were not instructed to take off their aspirin, things like that. So that's why we do the lab work beforehand. So, you know, it's not without complications, but the complications are generally well tolerated. So, you know, in this environment now, here's where I want to shift and really talk about how this really affects you. You know, we had an opiate crisis, so we're still in an opiate crisis for the last few years. And, you know, while opiates are great for a subset of patients, for some patients, they say, what else is available? And so they'll go to their doctor and their PCP, and the PCP will say, this is all I really have in my toolbox. Let's go to a pain physician. But not everyone has that ability. So it's really important for you to know that you can advocate for yourself and say, I need to see pain management. I need to see a pain physician. Who's doing this? What are my options? You know, like I said, we get a plethora of advertisements for medications, but we don't get advertisements for new medical devices that are really life-changing, like spinal cord stimulation. So this is the time for you and for us also to advocate for you on your behalf to say, have your PCP put in a referral to see pain management and talk about other options. Because I'll be honest, oftentimes by the time I see the patient in the clinic, they weren't even aware of all the things that they could have had to help them with their relief. There's also insurance concerns and challenges, and we'll typically help you navigate that. This is one of the most covered services, so it shouldn't typically be an issue for coverage for most plans. So I just want to close here to give you an idea of the algorithm that we use when we talk about pain therapies. We typically use something called the S.A.F.E algorithm, or the S.A.F.E analysis. Number one, is it safe? Okay, what are the complication rates and how do they compare with other therapies? Okay, number two is appropriateness. This is not going to be appropriate for every patient in pain, and I want to make that very clear. But there are some subset of patients who this will be life-changing for, right? And so we want to make sure that the therapies that we provide are appropriate for you. We want to make sure that it's fiscally neutral, especially in this environment of healthcare, where sometimes health insurance premiums are, quite frankly, like a mortgage. You know, you want to make sure that this is going to be covered, you're not left with out-of-pocket bills, and that if you didn't do this, what would your out-of-pocket bills be for seeing the doctor every month or for your medication costs, right? We want to make sure that this provides some fiscal neutrality as well. And most importantly, that it works. Right? There's nothing worse than you put something in and it just doesn't work for you, or you tried something and it doesn't give you the result that you're expecting. And that's what I love about this therapy, is that you can trial it first. You're given a week to trial it to see if it's going to work for you, which programming you like, before we make it permanent. And then, you know, I really do want to talk about how we can find a physician to talk about your treatment options. This is a really great website. I'm not sure if you've checked it out. I just recently learned about it. It is fantastic. It's www.askaboutpain.com. And it kind of just tells you about the options that are available for pain control. Where do I find a pain physician? Who's doing what where? And put you in contact with providers. You know, I know where to go for a restaurant for dinner with Yelp. I know where to go for, you know, to get most things because of these Yelp reviews. But I always ask the people around me, my friends and colleagues, how do you know how to find a good doctor? How do you know that the person you're going to see is legitimately going to help you? What's their experience like? And so this is a great resource, a great website to find some treatment options and the physicians that are providing these options for you. So that's about it for me in terms of the presentation. I hope this was helpful. It was sincerely a pleasure, and I thank US Pain Foundation for this opportunity. So I'm going to actually open it up to questions. I'm going to stop sharing my screen. There we go. And open it up back to Emily and Nicole for some questions.
Yeah, thank you so much. That was incredibly interesting and informative. I think I don't know if people are like me, but I've heard a lot about spinal cord stimulation, but never really a lot of details about how it works and what it works for. So that was great. Thank you. So we have had a ton of questions come in, and I've been monitoring those on Zoom and on Facebook. Again, if you're joining on Facebook, just type them into the comments. So we have a bit of time, so we're going to do our best to get to as many of them as possible. Just one note is that Dr. Shah can't answer like really, really highly specific medical questions. Obviously, she's not, acting in a place to represent your clinician at all, but we'll do our best to answer them as much as we can. So the first couple of questions that I wanted to ask was one that I thought was kind of interesting because it has to do with COVID-19. And someone who has a spinal cord stimulator implanted, but they have said that they haven't been going into appointments for adjustments and sort of tuning the settings because of the pandemic. And so they were wondering if you had any advice for sort of someone who's in that situation where they're trying to balance getting pain relief with, being at risk of COVID-19.
Yes, that is a fantastic question. And quite honestly, that is something that we also struggle with as physicians. So one of the things that you could try to do is typically we bring the patients into the facility to do the adjustments and to do the reprogramming. What I've been seeing lately is some patients can call their rep, and the rep can actually meet you at home. That way you're not exposed to the facility or you're not exposed to the virus. Although you can get the virus from anywhere, but it really helps mitigate that risk for you, especially if you're high risk to get the virus, such as elderly or be debilitated by the virus. Mm-hmm. So that's something I'm seeing, is that the reps can actually, they're so accommodating, really, and they can really find something that's going to work around your schedule, your location to help you during this time. It's a challenge for all of us.
Great. Okay, great advice. Thank you. We also got a couple questions about the batteries, which I think is a common concern amongst patients. So the first one was, how long does a battery last and what happens when it needs to be replaced? Do the leads need to be replaced as well?
Good question. Okay, good. So let's talk nuts and bolts. The batteries have become so sophisticated in the last really 5 to 10 years. They're very, very thin now. There used to be a lot thicker. And the battery replacement really depends on how often you're going to be charging the device, how often you're going to be using the stimulator. And that makes sense for anything that needs a battery, really. So the more often you're going to use it, the likely that you're going to need to replace it around the 6 or 7 year mark. But if you find that you're not using the device as often, or you're using programming that requires less energy, you probably could extend that life of the battery. When it comes into changing at the battery, it's again, same day surgery, fairly quick process. We just reopen that incision, swap the battery out, and replug in the leads. So we don't need to make any other incisions. You don't need to have your leads taken out. Typically, that's the way we do it, just swapping out the battery. Now, some of the newer batteries have a lot more new programming capabilities. And sometimes your doctor may say, you know what, I really would like to switch out your leads because these leads can give you a lot more complex programming if we use this new battery. So really talk to your physician. The reps are fantastic as well to give you some insight into what's possible. But typically we just swap the battery out and close it back up and you're out.
Great, thank you. Another question sort of along the lines of adjustment is someone that has a spinal cord stimulator that's helping with their legs, but it's not helping as much with their low back pain. Is it possible to reprogram it for other parts of the body without more surgery? Sounds like you probably would need to move the leads. But
yes, it depends. This is one of those questions that kind of depends. It depends on where the leads are, but nowadays with the programming, you can try to see if you can capture other parts of the body, assuming that, remember that green spinal cord that I showed you, assuming that the leads are placed in proximity to those areas, meaning if the leads are placed in the proximity for the back or for the legs, we're not going to be able to get the arms. We're just not, the arms are up higher. So just keep that in mind. We can get it so long as long as it's in the territory of that spinal cord that we talked about.
Okay. And that actually brings me to another question I saw from someone, which was about that placement slide. They said that they didn't see on the placement slide an area that maps to the arms. And so they were wondering if that was a different spot or someone's paying very close attention.
We have a very, very intelligent audience. Yes. So that was your lumbar spine. So as we move up, your arms will be in your cervical spine. So what I was showing you is a cross section of the dorsal columns, which is the back portion of your spinal cord, of your lumbar spine, your L levels.
Got it. So then we have a couple questions about, complications and contraindications. Someone was saying, this is actually a question we received beforehand. It's a person that is in their 80s and they're interested in a spinal cord stimulator, but like some doctors are telling them, it's worth it. Some are saying, it's risky because of their age. Do you have any thoughts about, age being a contraindication for having an implanted spinal cord stimulator?
Age is not a absolute contraindication, but I'll tell you, you want to do the least invasive thing for the patient without being too aggressive. It really depends on the physical fitness of the patient. I've seen some 80-year-olds that, quite frankly, would beat me any day at the gym. They're in fantastic shape. So I wouldn't say it's an absolute contraindication, but just looking at the patient's overall health. And that's the general advice I could give you.
Okay. And do you have any other words of advice just about contraindications in general, or things that you look for that might, you talked a little about a few of them and the things that you might screen out for in the process, but just generally speaking, what are like the big things that might make you say, this isn't right for you as a patient?
Yeah, the big things are if you have anything in the spine, any abnormalities such as tumor or foreign bodies or any bleeding abnormalities. If you are more prone to bleed when you cut yourself or you cut yourself shaving, that would be a relative contraindication. That's typically the contraindications. Yeah.
Okay. And that actually ties into another question we had gotten from someone about sensitivity to metals. They said that they were really interested in getting a spinal cord stimulator, but they're concerned about that sensitivity. Is that a factor at all?
It is. So it depends on, you want to speak with your physician and definitely with the representative in terms of what the metal allergy is. Is it to nickel? What is the allergy to? And to make sure that the battery is not made of those metals. So that is a very, very common question, very easily answered. Just speak with your physician and the manufacturer.
Okay. And another one, I see a lot of good questions coming in from the Q&A, so I'm doing my best to monitor those as well. But another question someone had was, if you could explain overstimulation, which is something I've never heard of, but and they asked, how do you know if that is occurring?
Overstimulation.
Yeah, I'm not sure entirely if that's okay. Maybe they.
Yeah, I can try to deduce what the question may be asking. Maybe if the stimulation is too strong for them, if that's what they're experiencing, you can definitely dial it down and program alternative programs or just decrease the amount of energy that you're receiving. That's probably what they're referring to.
Gotcha. Okay. I'm learning too as our questions come in. So another thing I wanted to do is that we've gotten a lot of questions from people about their specific condition. And so I know that you can't like go into a lot of detail and, people will need to speak with their healthcare professional. But I thought what we could do is, I don't want to call it a lightning round because that sounds scary, but basically I just want to name a few conditions and have you just say, yes, no, it's indicated, and sort of what your thoughts are, if you have any. So the first one was Ehlers-Danlos syndrome. And
okay, EDS. So I see quite a bit of EDS, both juvenile, meaning children, all the way up to adulthood, and it runs the gamut. So this is one of those that I would say we really need to see you in the office and to examine you and to get an idea, because there are so many facets to this syndrome, so many facets, from the heart to the lungs to the joints. So really, it's one of those things that we need to examine individually.
Okay. Another one was about treating both lower and upper back pain at the same time. Is that possible?
Oh, yes, that's a great question. That's a
Okay.
really great question. We commonly see patients who were in a motor vehicle accident, right? And then now they've got a herniated disc, they've tried everything, they still have that pain down the arms. And then we put in a spinal cord stimulator for them and they're very happy. And then as they age, they'll come back to you and they say, doc, I think something's going on with my lumbar spine now, my low back, and I've got the same kind of condition where I've got a herniated disc and it's going down my leg. Can we use the same technology? And the answer is absolutely. And some of these new generators, which is the battery, can actually accommodate quite a few leads so that we're able to treat multiple locations at the same time. So we can get that neck pain and the arm pain, and we can also get the low back pain, all with this one battery.
Got it. And that's so important because that's something we talk about a lot at US Pain, is that your pain often will change over time. It's, you have to keep kind of adjusting your treatment plan. So it's good to know that spinal cord stimulation has that flexibility built in. So continuing with our lightning round of different conditions, someone asked about Tarlov cyst in the spine. And I know you said earlier that might be a contraindication if there's some sort of like defect in the spine. So do you think that could help for pain from a Tarlov cyst?
Yeah, that's typically in the sacral spine, but although it can
Okay.
for other places. So it really depends. If it's in the sacral spine, then these leads go in the lumbar spine or thoracic spine, so they're higher up. But again, it kind of depends where the cysts are. But they
Okay.
can pose a challenge to putting in these leads.
Okay, so possibly, but definitely just need to, be mindful. Okay, another one was someone who has pain due to multiple sclerosis and degenerative bone disease. I'm assuming that would be a yes, based on what you've.
Yeah, MS pain, we see quite a bit of MS pain, multiple sclerosis, and they do fantastic with the stimulator. And then the other one was degenerative joint disease.
Yep.
Of the spine, I'm assuming.
Yeah,
Yeah,
they didn't say.
great patient to treat low back pain. Yeah.
Okay. Okay. Another one, and I think this has come up from a few different people, but they're asking about pain in either the abdomen or the genitals, if either of those more like core areas can be treated by spinal cord stimulation.
Absolutely. And I'll
Okay.
tell you one thing is that when you talk about pelvic pain, and whether you're male or female, it's a very sensitive topic, sometimes so sensitive that you don't really bring it up to your physician, or sometimes the physician says, okay, we'll talk about that later, because it's a very difficult topic to discuss. But this is a fantastic option for someone with pelvic pain. And it really depends what type of pelvic pain. If it's more musculoskeletal, it's not going to be as effective. But if it's coming from the sacral nerve, sacral plexus, I have found a lot of benefit for this.
Thank you. Good to know. And I just have, let's see, there's 3 more specific conditions that I wanted to ask about for folks who have been typing in their questions. So one was about neck and shoulder pain. So we've talked a lot about lower back pain, but can the leads be placed in a way that can help with upper back issues?
It can. It depends on the etiology, which means the cause of the back pain. If the back pain is structural, maybe surgery might be more of utility. It really depends on the condition. But it's something that you should definitely talk to your physician about and say, is this an option for me?
Okay. So just 2 more. So another question I thought was really good actually was about complex regional pain syndrome, also known as CRPS. And they were describing how, that type of pain and, with nerve pain in general, it can be bone pain, icy burn, like a fire type burn, can involve muscle pain. Can a spinal cord stimulator affect all those different kinds of sensations, or how does that sort of work?
Absolutely. It is what, for the patients that have CRPS and you see them after a stimulator, it's life changing for them, because they're now able to walk, do physical therapy, lead a normal life. It's black and white. So it does work for CRPS pain, whether it's of the upper extremity or the lower extremity, foot, ankle. Typically after ankle surgery, we see it quite often that patients develop CRPS of their foot. A fantastic option to help treat it.
Okay, good to know. And then another one that we had a couple write-ins about beforehand, and you and I talked about this briefly, but I feel like it's a good note for people to have, is we had some people ask about spinal cord stimulation for their knee. And so I didn't know enough about spinal cord stimulation to differentiate what they were asking about. But could you talk about the point of confusion there and what we think their doctor was talking about using for the knee?
Yes, we can use spinal cord stimulation for knee, particularly if it's a neuropathy of the knee, things like that. But he may also be referring to peripheral nerve stimulation, which uses essentially the same type of electricity or technology, but it's usually used in specific locations such as the knee or the joint or things like that. So I'm not exactly sure what he was referring to, but it could be either peripheral nerve or spinal cord stimulation. So there's
Oh, okay.
a lot of options.
Oh, okay. Okay. Good to know. Yeah, I think they both had said their doctors had mentioned stimulation for their knee. So, and it was just interesting to me because I'd never heard of
Yeah.
knee stimulation specifically. Good to know that both of those types are available. We also have a question on Facebook. Someone is asking for their child who has CRPS, and they wanted to know the difference between sympathetic nerve blocks versus nerve stimulation, and are they the same?
Good question. No, they're not the same. So the sympathetic nerve blocks will actually work on what we call a plexus or a ball of nerves that are giving the sensations that you're experiencing, the hot, the cold, the change in color, all of those type of things. That's what a sympathetic block does. The spinal cord stimulation will give energy to the same area. Remember, it blocks the pain signaling. So the way it works is different. It's going to block the pain signals from even entering the spinal cord. So it's treating the pain, both treat the pain very, very effectively, but the mechanism is a little bit different.
Good to know. Okay, so we still have a ton of questions coming in, and I just want to say to everyone who's watching, thank you so much because these are fantastic questions. And I'm just trying to look through a couple more of them to see how many we can get to. Let's see here. Someone was asking, I wanted to pull this one up. So it sounds like placing these can be a little complicated and requires a good amount of experience. Does it require a lot of skill? And, what do you recommend about finding, the right provider to do a procedure like this?
Great question. So it does require an extraordinary amount of skill, both in technical placement, surgical skills, things like that. What I would recommend is that you find a pain physician who's boarded in pain medicine, meaning who has sat and taken the licensing exams. So you know that he or she has completed the training that's required in order to do this. It's like you said, it's highly skilled technique that's required. And so that's what I would look for, is for someone who has done a pain medicine fellowship and then who has also sat and passed the board exams.
Got it. And another question too, that's kind of similar is, and I think this is a question a lot of patients have, there's a lot of different devices available, which is, on one hand, it's fantastic that there's different options that can be, people can decide what's right for them. On the other hand, it can be really confusing because you have to, as the patient and the consumer, kind of figure out, what's right for you. Do you have any recommendations for, what to look for when choosing a device? Or any resources that people should look to, or any other ideas for helping kind of navigate that?
Yeah. So for me, one of the most important things is to have a conversation with the patient about MRIs and MRI compatibility. Some of the devices, you cannot have an MRI. So suppose, down the line, you have a stroke, or you need to get an MRI of your shoulder because now you have rotator cuff problems. Things like that preclude you from getting an MRI are things that for me are very important. So have a discussion about which manufacturers make MRI compatible leads, MRI compatible paddle leads, which is if you need a neurosurgeon or a spine surgeon to place in a little bit of a larger, wider lead, that's called a paddle lead, and to make sure that those manufacturers have MRI capability as well. So that's
Okay.
one of the most important things I would ask.
Okay. And can you speak at all to sort of the different types of stimulation that can be provided? So I've heard a little bit about there's like high frequency, I think it's
Yes.
called, or burst, and trying to pick between those.
Yeah, and the important part about that is that you find a company that can give you options, that they can do high frequency, they can do conventional frequency, they can do burst or complex programming. That's number one. And number two is it really depends on what you need. So for example, if you've got back pain that goes down the leg, you may want to have paresthesias because that vibration signal is soothing for you, or you like that signaling. Some people say, look, I don't want to feel anything, just turn it off, but I never want to go with the paresthesia sensation. So there's those companies for you too. But my preference would be to go with a manufacturer that has the option of doing both. They can provide conventional, and you may like it. And that's what the trial is for you to have a lot of options during that 3 to 7 day period to say, here's what I like, doc, here's what I don't. I like it when you can move it left and I can feel the paresthesias on my left low back, but on my right low back and my right leg, I don't want to feel it. Those type of things are possible.
Okay, thanks. And another question I think that, and I know we're coming up to the end of our hours, just a couple more questions we'll try to squeeze in here. So another question that I think is important to address is, what is the percentage of failures with SCS? And I know there's a couple things that can, go wrong, as you mentioned, but sort of, how likely are those things to happen? And also, what should patients be looking out for once they've had it implanted?
You got it. So failure is an odd term because I'm not going to say failure from the implant. Let's talk about the trial first, right? And that's where we really make the decision or the algorithm to say, let's move to making this permanent or let's not, right? So the failure rate is from the implant is relatively low because we already did a trial. We got a great experience out of it to know if this is going to work or not. And typically we can remember those 3 endpoints that we talked about? You may not get 50% pain relief, but if you come to me and you say, I'm not even using my medication, I'm more functional, I get better night's sleep, well, that's success, right? That's clinically meaningful success to me and you. Or if you come in and say, I've got 50% pain relief, but I'm still using my meds, I'm still doing other things, that's okay. 50% is huge. So, it really depends on how you're going to define success. Some patients say, I want to be off these meds. Quite frankly, they're making me too sleepy. I'm taking too much. It's interacting with all the other stuff. And I just want an option that I don't need for medication. And this works for me. This is good for me. Yeah.
Okay. Good to know. And I love the chart that you included that showed sort of the likelihood of having different problems. Okay. And like with any procedure, there are always risks, and like with any treatment, downsides, pros and cons, and you just
Yes.
have to weigh them based on your specific situation. So last question, since we're just 5 minutes away from the end of our hour, is we're getting a lot of questions on Facebook about affordability. And so we were wondering if you could just speak to, sort of who covers it, is it well covered, anything that patients need to be on the lookout for when assessing whether this is an affordable option for them.
You got it. So number one, it's FDA approved. So that's important to know. Number two is that this is covered through Medicare. So if you're Medicare beneficiary, this is a covered benefit for you. Most private health plans, what we call commercial health plans, HMOs, PPOs, this is also a covered benefit. So if you're a Medicare beneficiary, it is covered. Sometimes they'll cover a portion of it, and that's when your secondary will kick in to help cover the cost of it. So this is by most health plans covered benefit. But the good thing is that if you're interested in this, we can always do something called a prior authorization. So we just run it through the insurance company, give them a call and say, is this a covered benefit? If so, how much will they be out of pocket? Typically you're out of pocket by your deductible. And that's something we all have, right? A deductible. So you can get an idea if it's covered or not just by doing a prior authorization.
Great. Okay, well, I think that's all the questions that we have time for today. To those of you whose questions we didn't get to, I'm, so sorry about that. But the good news is that we're going to be talking more about neuromodulation throughout the month of November, and going into all the different types, spinal cord stimulation and beyond. We mentioned peripheral nerve stimulation earlier, and it can be really hard as a patient to understand all the different options and TENS versus PNS versus SCS and all the abbreviations. It can be like alphabet soup a little bit. But hopefully we got to a lot of your questions and you found the information helpful, or maybe your question was answered during the PowerPoint portion of today. So Dr. Shah, I just want to say thank you so much. We really appreciate it. And just so everyone knows, Dr. Shah is in the area of California where they're dealing with fires and evacuations. So her joining us today and being present is truly, we're really grateful for you, because it cannot be easy with all that's going on. So we thank you from the bottom of our hearts for joining us today, despite everything. We really appreciate it. So thank you. And again, those of you who are interested in neurostimulation and neuromodulation, we are launching a campaign all next month that's going to, again, be reviewing all different types, and we'll be going more into SCS, but also other types as well. So we hope that you'll check that out. We'll be announcing that theme. You guys are getting a sneak preview, but we'll be announcing it more fully next week. And we'll even have a fun prize for you if you join a couple of the events. So thank you everyone for joining us today. We appreciate it so much. We hope you learned a lot. And thank you, Dr. Shah. And thank you to our sponsor, Boston Scientific. And we hope to see you next time.
Thank you.
Thanks, guys. Take care.